I think first we just gotta, good.
Yeah, you go ahead.
All right, good morning. Can everyone hear me?
Yeah, good morning.
Wonderful. So good morning and welcome to the first meeting of the Task Force on Maternal Health Access and Birthing Patient Safety. My name is Alicia McGregor, and I'm a faculty member at the Harvard Chan School of Public Health, as well as a board member here at the Health Policy Commission. First, I want to take the opportunity to thank each of you for bringing your time and your expertise to the table at this moment, particularly as we all have a lot on our plates as we navigate everything that's taking place politically at the federal level. So your commitment to this work at this time in particular is most appreciated. Now, we're all here today because of the landmark maternal health legislation that was passed last year. And that legislation, Chapter 186, assembled this task force of experts and practitioners to help both assess and shape maternity care in Massachusetts in a fashion that is much more equitable, accessible, and in line with the most recent evidence on risk-appropriate care. As all of us at this table know very well, we face a maternal health crisis, both here in the Commonwealth and nationally. And it's a crisis that's characterized by stark racial inequities in morbidity and mortality, as well as high and rising rates of severe maternal morbidity. And this is occurring alongside a contraction of healthcare services, which includes recent closures of obstetric units and birth centers in the Commonwealth, as well as larger health systems issues, such as workforce pipeline issues, layoffs, and more. So an overarching goal of the legislation is to expand the options for birthing care that are available, as well as to strengthen the maternal health care workforce, to include midwifery and to value midwifery in a more robust way. And so the work that we do here today will help lay the groundwork for this expansion of access. And so because of the legislation and because our work is laid out pretty specifically in the legislation, we all know more or less what we're here to do. But there's some latitude as to how we do it that will really make a difference in the impact of this work. Fortunately, here in Massachusetts, we have the benefit of an existing set of recent reports that have created a really excellent foundation on how we understand our contemporary maternity care landscape in the state. These reports include the Special Commission on Racial Inequities in Maternal Health 2022 report, the DPH's 2023 report on severe maternal morbidity, as well as the Department of Public Health's 2023 review of maternal health services, which was circulated at the end of 2023. And this is all in addition to a body of work that's been compiled by the HPC on access to midwifery, the costs of caring for severe maternal morbidity, and more. So we're not starting from scratch, but we'll work together to build upon our existing set of knowledge to add the breadth of analyses as well as actionable policy recommendations to what is already known. And also, and I'm happy to say, we have the benefit of the newly established Office of Health Resource Planning at HPC, which will bring their incredible expertise and leverage a diverse set of health systems data sets in this critical work. So over the next several months, we'll work together to finalize a plan, execute a mixed methods analysis, or really a set of mixed methods analyses, because we do have quite a lot to do, and we will be doing quite a lot. And at the end of all of this, we will summarize our findings in a report to the legislature at the end of the year. And so I'm excited to work with each of you, especially to work alongside Dr. Alonso Lord. And with that, I will turn it over to Dr. Alonso Lord to also provide some opening remarks. Thank you.
You gotta give it like,
You have to hold
it's like a one Mississippi. And then release.
Oh, there we go. My skills are not in tech. Good thing I don't work there. Good morning, everybody. Thank you so much for being here, for the task force for coming, for responding to the call. You were designated by the bill to be on this. And thanks for those of you who are in the public too for coming. I know, as Dr. McGregor said, we all have a full plate and that plate is getting fuller and fuller. So thank you so much for being here today and for once again demonstrating your commitment to improving our maternal health system and landscape. I want to talk a little bit about how the maternal health bill has impacted our work at the Department of Public Health. I'm honored to serve as the Division Director for Pregnancy, Infancy, and Early Childhood. Don't worry about all of what we do. We basically call ourselves PIE, which is sort of ironic, but it is also demonstrative of the culture of PIE, where we take a very dyadic approach and we recognize that there is no parent without a child and there is no child without a parent. So everything we do goes through that lens. It goes through the lens of how is this going to impact families? And it's not just how's it going to impact the mom or the dad or the parent, it's how is it going to impact the two of them and their attachment and the fact that families exist in a community. And that community could be active, it could be grandparents and people living nearby, or it could be an online community that's supporting a mom at 3 a.m. when she's trying to breastfeed. We all know what that looks like. Since the bill was passed on August 24th, I don't think anybody at the Bureau of Family Health and Nutrition will forget that day. We jumped into action to first understand what it said in the bill and what that would mean for our work. And I want to highlight a couple of important points building on on Dr. McGregor's opening statements. And to do that, I want to take you back to 2016 to a Lancet Commission on Maternal Health that proposed a theory of maternal health services called Too Much Too Soon, Too Little Too Late. This is a landmark paper that in the work that I've done in maternal health in my life, I think I'm one of many that constantly goes back to this framework of we're constantly seeing people getting too much care too soon. And at the same time, in the same places, they're getting too little care too late. And this is where we're seeing the excess in morbidity, maybe because people are getting too many interventions because we lack a midwifery model of care integrated into the healthcare system. And at the same time, we lack critical obstetric services in places where they've closed down. Both things are happening at the same time. In Massachusetts, we know that that's worsened by racial equities, and we know it's going to get worse by people whose documentation status, not that it's not there, it's that it's complicated for them to understand, and they're losing the perception of the right to care, not just because they don't have the documents, but because they think maybe those documents mean that they can't show up at a hospital. So they might be showing up too late or they might be showing up too soon. We still don't know that. So a lot of research that we've done, we have a lot of answers, and there's a lot of research that we haven't done. We don't know how it feels to be a nurse in the OBED right now. We've heard about it from meetings. We have met with hospitals. We've met with hospitals in places where they're taking the overspill of clients, patients, families who don't have access in Leominster, people who wanted a birth center birth and they can't have it, and they're showing up at MGH saying, I want a water birth in a tub with a midwife. And MGH says, sorry, I can't help you. We're seeing people in Leominster showing up at the emergency department, and the EMS services are now becoming experts in transporting people who might be about to have a baby. That's the research that we haven't done yet. Two things that we've really taken on in the Department of Public Health, of the many things we've taken on with this bill. And I want to focus on these two just for a minute. One is the integration of community birth. And the way that we've tackled it is as a theoretical shift in how the system understands service delivery. It's not about putting midwives in the system. It's not about opening some birth centers. It's about integrating birth in the community as an option for families. And what that means is that people are pregnant in their communities. That's where they live their life. They give birth, and that birth, the baby might come out in a facility or it might come out at home. But most of the birth actually happens at home. You go into labor at home, or you decide to be induced at home at your kitchen table with your partner, making that complicated decision. You decide to have a scheduled C-section, asking your friends, should I do it? Should I not? What do I do? These are decisions that we make in the community. When you get released from the facility or the birth center that you had your baby in, you go back home. The first week is at home. You try to breastfeed at home, or you try not to breastfeed at home. You stay up late at night at home. All of this is happening in the community. And so what we're really trying to build out in the Department of Public Health is understand the linkages between the facilities and what's happening with maternal health service provision and what's happening in the reality of community life. So where are the doulas? Where are the home birth midwives? Where is the remote blood pressure monitoring? Where are the lactation consultants that are showing up at your house? Where are the nurses that are showing up at your house for that one-time postpartum visit? And realizing that you look like you're doing okay, but you aren't. And it's not just that maybe this hurts or your section hurts or your baby's not latching on. What's going on is actually something much more complex. And if somebody would sit with you for an hour and a half and listen, in the last 15 minutes of that visit, they're going to figure out what's actually going on and be able to refer you quickly to some services that might be able to provide you some support. And then how do we extend that to home visiting in general? How do we make sure that that one-time home visit actually becomes a system of support? If your child needs early intervention services, if you need substance use support systems, anything that might actually happen to make your life as a parent in the community stronger, healthier, and better. The other big piece that I want to talk about is very specifically the expansion of this one-time home visit. And this model is actually revolutionary because our facility-based care is very much focused on you come to the facility, we provide care for you, and then you go home. We know from all of the reports that Dr. McGregor mentioned that the one-time home visit during the postpartum period was mentioned several times as a recommendation. And we also know that in the home-based midwifery model of care, what is so effective about the outcomes of the midwifery model in the community setting is the fact that the midwives embed themselves into clients' lives. They know what the mess of the house looks like. They know what the relationship is with the partner. They know what the mother's relationship is with her own mother and how that's impacting the system of care. They know whether or not that person is scared of the hospital and whether or not they'll show up at the ED if they need help, whether they'll call their PCP or whether their PCP was rude, mean, dismissive of them, and why bother because they're never going to listen anyway. So we've been doing some very careful thinking about how do we go from a service that's available right now in 7 communities to expanding that to 351 communities, bam, off the start, because we can't scale it up. It has to be available for everybody. That is the right of residents of the Commonwealth. As we think about that, we've been thinking about what does that visit mean as an integral part of the system so that we can push the system so that we're looking at maternal care, not as something that happens of how do we expel a baby from a uterus in a very Monty Python approach, but of how do we understand that parenting is a deeply transformative experience for everybody's life. And that as a society, as a culture, and as a Department of Public Health, we have every obligation to make sure that our services are at the feet of those parents and they're at their homes so that as soon as somebody needs those services, they can connect into them. This report gives us the opportunity as a task force to bring together all of our brilliant minds. The fact that each one of us sits in a very different place in the maternal health system means that the genius of this task force is that we can bring in the very complicated quality of care of level 4 hospitals, the importance of community-based birth centers, the importance of research, qualitative, quantitative, the importance of what does this mean to the medical community? Bring it all together with an aspiration that graph that we've seen so many times of maternal morbidity going up, 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 we're going to start seeing it go down, 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 down. We're going to start seeing, I have an Excel that's always open on my computer. That's the community birth rates. How many people were born at home? I want that to reach 3,500. That's my goal, 5% of babies born in the community. But I also want to make sure that the people that need and want to go to a hospital in the Leominster area, on the Cape, in Western Massachusetts can get there within 20 minutes so we don't have babies being born in the car. I want to make sure, too, that all of the services that are so complex and hard to get to, we're able to weave them together and that this report is the platform for that model of care going forward. So thank you everybody so much. We have a lot of work to do in short time, but we're good at that. That's why we're here. Thank you and welcome.
Right. Amazing. Thank you so much, Dr. Alonso Lord. All right. So at this time, let's turn to member introductions so that we all sort of take an opportunity to get to know each other. I know some of us know each other. For others, we're meeting for the first time in person. So let's ask everyone to take a minute or so to briefly introduce themselves. And why don't we start over here?
Hi, good morning. So I am Dr. Sepoku Godwin. I'm an Associate Director of Research at the Betsy Lehman Center. Over the last 5 years, I've been involved actively in working on severe maternal morbidity, working with Kristen and the DPH as well, just to see the landscape for severe maternal morbidity. What can we do about it to at least stem it and also break the disparities that we have been seeing in the data? So my focus has really been mostly on the disparities part of it and trying to see how we can, ensure everybody has a safer birth in the state.
Thank you.
Give it a press. Yeah.
How's that?
Yeah. All right. Good morning. My name is Nishira Burrell. I'm the founder and executive director of Neighborhood Birth Center. I'm a public health person by training, governmental public health, maternal and child equity, and have been working to open the city's first birth center for the last 10 years. And we're also looking to explore a birth center in Lynn, Massachusetts as well.
Morning, everybody. Excuse me. My name is Kristen Price, and I'm the Administrative Director for PINQUIN, which stands for the Perinatal Neonatal Quality Improvement Network, which is our state perinatal quality collaborative. Things that are relevant to this work in particular is we've been involved working really closely with the Betsy Lehman Center and DPH around levels of maternal care. We've also worked really closely with the Health Policy Commission around remote blood pressure monitoring. And there's a lot of other things that we're working on, but we actually have our ability is to convene the providers in the state, so and get a lot of input. So I think we'll be able to bring back the voices to this task force. Thank you.
Hi, I'm Amy Gagnon, and I'm here representing the Massachusetts Nurses Association. I unfortunately was involved in one of the labor and delivery units in northern Worcester County that just recently closed at Leominster Hospital. And I'm now still doing labor and delivery. I've been doing it for 16 years at Hayward Hospital, which is still part of northern Worcester County. But we unfortunately are at almost at the point too where we're going to be needing some help. We're seeing a lot of these units close because we're servicing the low income patients. A large majority of our patients are Haitian Creole and really do need our services. But unfortunately, we're not able to make a ton of money like the bigger tertiary care centers. We send our patients to UMass Worcester, which is still a 40-minute ride. So it is important that we still keep these labor and delivery units open in northern Worcester County, Greenfield area where patients don't have access to care.
Lee Simons, I'm the Senior Director of Healthcare Policy for the Massachusetts Health and Hospital Association, where I oversee our public health and behavioral health policy work. I think relevant for this group prior to MHA, I worked for the Massachusetts Council of Community Hospitals. So very aware of the challenges facing community hospitals in the Commonwealth.
Hi, good morning. My name is Sarah Shields. I'm a family physician working in Worcester, and I'm here representing the Massachusetts Medical Society, where I was the former chair of the Committee on Maternal and Perinatal Welfare, and the society has been a strong advocate for this maternal health bill. I also do wear a hat as a family physician who has attended births for 30 years, and reminding us all that family physicians do play a role in all aspects of birth care in the Commonwealth, and I want to make sure we remember to include family doctors in this. Hopefully not too many of us are the kinds of primary care doctors who don't listen. I hope we all listen. But that's part of what I'm here for. Thank you.
Hello, I'm Hong Trill. I'm Senior Director of Research at CHIA. And in my role at CHIA, we are really the provider of data sources, including the case mix of provider surveys and hospital cost report, which would really help track the hospital services and maternal care in the Commonwealth.
I think we need to introduce ourselves again. So such a pleasure to have each of you at the table at this critical moment for this work. So at this time, I'd like to begin by introducing David Seltz before we dive into the specific work of the task force. First, we will talk a bit about existing research that was conducted by the HPC, as well as describe the legislative mandate for this task force. And at this time, I'd like to invite HPC Executive Director Seltz to present some of this recent research on severe maternal morbidity, as well as to discuss recent policy changes to address these concerning trends. Thank you.
Good morning. Thank you. I'm David Seltz, Executive Director of the Health Policy Commission. Thank you, co-chairs and members of this maternal task force for the opportunity to present to you this morning at this kickoff meeting of this really important task force. Thank you all for your participation and engagement and commitment of time to this work. We at the HPC are really excited about the opportunity for this task force and the aspiration of the work that it can accomplish. We're grateful for all of your varying perspectives that you will bring to this work across the maternal health workforce and patient community to be represented here. We at the HPC have been committed to working to address unacceptable inequities in maternal health access and disparities in birthing outcomes in communities across Massachusetts through our research work and our investment work and our convening work for many years. At the outset of this task force, I do want to acknowledge some key legislators who helped work on the omnibus maternal health care bill that passed last session and established this task force. Senator Friedman and Representative Decker were the co-chairs of the conference committee of the legislature that negotiated the final version of this maternal bill, as well as Senator Miranda, Senator O'Connor, Rep. Mike Moran, and Representative Ferguson all participated in the negotiation that extended beyond the end of formal sessions and resulted in a unanimously passed bill in August. I think really representing the importance of this work and the recognition that even though formal sessions had ended, this work was too important to not continue to press forward. Leaders Mariano and Senate President Spilka, I think, also deserve a lot of credit for continuing to make sure the legislature completed this work and executed on this really important bill. I'm personally really excited that you, Dr. McGregor, have agreed to serve as the HPC's designated co-chair to this task force. You have a critical voice in maternal health equity, not only in Massachusetts, but nationally. And I know that you're just going to be a really insightful co-chair to this work. The goal of this task force really builds on the landmark work of the Special Commission on Racial Inequities in Maternal Health, which was mentioned earlier. This commission really highlighted the need to improve maternal health outcomes and experiences for historically and currently most vulnerable residents in the state of Massachusetts, and had a particular attention on racial inequities. So to set the scene for the work of this task force and why this is so crucial, we wanted to open with just a few data slides and recent findings from the Health Policy Commission, largely drawing on data from DPH on severe maternal morbidity in Massachusetts. As shown on this slide, alarmingly, despite performing well on other metrics of reproductive care and women's health, and frankly being one of the healthiest states in the country, we do understand that Massachusetts has the 4th highest rate of severe maternal morbidity in the United States. Massachusetts on average of 819 cases of SMM annually between 2019 and 2022. And we know that many of these cases are preventable with the right type of high quality care. It is also well documented that people of color are much more likely to experience SMM than their white counterparts. To better understand how racial and ethnic disparities impact severe maternal morbidity in Massachusetts, we analyzed hospital data in this slide and found that between 2019 and 2022, Black non-Hispanic birthing people had a rate of SMM over 2 times higher than white non-Hispanic birthing people in the Commonwealth. This alarming data correlates with further HPC findings that Black birthing people in Massachusetts receive less prenatal care than birthing people of any other race or ethnicity, as shown in the orange bar here on this graph. 4 percentage points below the closest racial ethnic group and 13 percentage points below white birthing people. These inequities in maternal health access and outcome are occurring in parallel to closures of hospital maternity units and other access points for birthing care across the state. As of this map is current through October 2023 and was developed by the Department of Public Health, shows that 39 hospitals in Massachusetts now offer labor and delivery services, representing about 960 beds. Since 2014, however, 11 hospitals have closed or have filed to close their maternal services, and 2 birth centers in Beverly and Holyoke have also closed. We also know that the recent bankruptcy of Steward Healthcare disrupted access to healthcare services across Massachusetts. So I think an important charge of this task force will be to update this data on maternity ward closures, birthing center closures, so that we have really an up-to-date and accurate understanding of the gaps in access facing Massachusetts residents. I think promisingly, though, in addition to the establishment of this task force, as was stated earlier, the state has really put together a really sound foundation upon which we can conduct this work. This includes, as I mentioned, the Special Commission on Racial Inequities, but also alongside many of the other DPH publications that were mentioned earlier on maternal health access. The Special Commission on Racial Inequities in Maternal Care really put together a tremendous report full of a comprehensive set of recommendations, many of which we've actually seen great progress on since that report was issued. I want to recognize that we at the HPC were a proud member of that special commission, and Jasmine Bland at the HPC staff was the designee from the HPC to that special commission, and is going to be working closely with this task force on the work ahead. I also just want to mention that Senator Comerford and Representative Decker were the co-chairs of that important commission. But in addition, since that commission finished its work, we've seen, as I said, progress in a number of areas, including the administration's Advancing Health Equity in Massachusetts initiative, which is really aimed to eliminate racial, economic, and geographic disparities in health outcomes. And as part of that work, they have included maternal health as one of the key areas of focus for this work. And we're excited to be able to work with our counterparts across UHHS on that initiative. And lastly, as highlighted on the slide, the legislation passed last session takes important steps to address some of the payment and workforce challenges facing the maternal health field in Massachusetts. This includes creating a licensure pathway for freestanding birth centers, and thereby increasing access to lower cost non-hospital birthing options. It also included expanded coverage for doula services and requiring payment parity for certified nurse midwives, two important providers in maternal health care that have been undervalued for too long. At this point, I want to offer an opportunity for co-chair to add some additional context on some of the work that has been happening in recent years.
Yeah, so coming back to the freestanding birth center regulation review, the bill called for the freestanding birth center regulations to be reviewed. This had already started happening within DPH, acknowledging that the regulations as they stood made it almost impossible to open a freestanding birth center, to the point we have one in the state right now. The revised regulations were published they were approved by the Public Health Council in February and are published now. They're available to the public. And two really important notes on that. One is that the staff of the freestanding birth center no longer need hospital privileges. They can be solely employed within a freestanding birth center. And the staff includes certified professional midwives, both as clinical staff and also as administrative staff. The second piece of that, of course, tied in is the regulation of certified professional midwives. Massachusetts is one of the few states, one of 11 states that still does not acknowledge the existence of this very specific professional that is an expert in community birth. And so the regulation again calls for the establishment of a midwifery board. This is an important piece of making sure that the regulations around certified professional midwives are designed by certified professional midwives that are experts in their profession. And so the board also was inaugurated in February. February was a busy month for community birth. And they have already met twice. They are working to promulgate temporary licensure by the summer and permanent licensure by the fall. This will also include access to pharmacological medications that they need to practice their profession safely. And it also includes reimbursement by Mass Health. So these are really critical steps to making sure that CPMs are accessible both for home birth and for birth center staffing. Because if we're going to open a lot of new birth centers, we need the staff. And then the second piece I want to talk about is doula. So you may know that Mass Health has been reimbursing doula services since January of last year. And so what we've been working on at the Department of Public Health is establishing a certification pathway for them. This is complex because there's no accreditation council for doula education. There's no national competencies. And so this has required a lot of community outreach and a lot of input from the doula community themselves to say, these are our standards. These are the standards that we hold ourselves up to. And also working with families that engage doulas in their services. What do we expect out of a doula? What is a quality doula? So we're expecting the doula certification to launch this summer, probably towards the fall, because when people get back from holiday. And so this will be an important step in being able to engage with facilities and say, this is what a doula is, this is what their role is within the maternal health team, and this is their role within the maternal health system. It'll also enable us to start collecting data on doulas, because we kind of go from, we don't really know what doulas do, to doulas will save the entire maternal health system. There is a medium point that we are sure that we can land on if we actually start collecting data. So starting the fall, the birth certificate will include information on, it will add variables about CPMs being your provider, your health, your prenatal and birth being able to be provided at home, in a shelter, in a birth center, as well as in a hospital or a clinic, and also whether or not there was a doula at your birth. So this, our partners at CHIA will be able to say, this is how we're actually seeing doulas impact the maternal health system. And finally, our certified nurse midwives, critical piece within facilities and also right now within birth centers. The law established pay parity for CNMs, and starting January 1st of this year, Mass Health has established pay parity for certified nurse midwives in line with physician rates. This has not extended to private payers, so this is the next frontier of this issue. Thank you.
Thank you. Finally, we just wanted to highlight some of the aligned work and investment by the HPC to improve maternal health. Building off of some of our past investment programs that focused on maternal and early childhood health, including the recently concluded BESIDE program, which worked to improve maternal health outcomes and patient experience for Black birthing people through increased access and use of doulas. Just last October, we launched our latest investment grant opportunity, a $1.5 million investment, which we call HEART BP, which stands for Hypertensive Disorders Equitably Addressed with Remote Technology for Birthing People. I had to read that, sorry. Through remote blood pressure monitoring, HEART BP will support 4 birthing hospitals and 1 community health center in their efforts to improve outcomes, lower costs, and address inequities. Awardees will monitor program access and engagement to ensure a high-quality patient experience for all populations, but especially for those with a disproportionate prevalence of hypertensive disorders or pregnancy and at risk of severe maternal morbidity. We will be supporting the eligible entities and making patient-centered remote blood pressure monitoring programs available to appropriate patients for a minimum of 6 weeks postpartum. And I really do want to recognize the work and partnership with PinQuin and Dr. Price in the development of this program and the implementation of this program. And we hope that the learnings from this program will be spread widely to help ensure continued adoption of this intervention. And it, of course, aligns with activities at Mass Health, which has recently extended coverage for this type of intervention. So we are really hopeful that this task force can build on all of this work that has been happening in Massachusetts and really take it to the next level. And so I'm happy to pause now if there's any questions before I turn into the charge of this task force as written in the legislation.
The thing that says Mass Health coverage, that's separate from the HPC grant?
Correct. Yep. Our grants will be supporting these hospitals and patients of all payer types, and it's not specific to Mass Health. So moving on into our ambitious mandate, Section 48 of Chapter 186 of the Acts of 2024 prescribed that each of your organizations has a seat on this task force to ensure that we have a diverse understanding of the landscape and the varying data necessary to complete this work. As you can see here, the task force is charged with studying the current availability of and access to maternal health care services across regions and across patient populations. This does include an analysis of the essential service closure process and the adequacy of the maternal health care workforce. Second, we are charged with identifying methods to increase the financial investment in and patient access to maternal health care services across Massachusetts and across different settings of care integrated into the community. And finally, our charge is to issue at the end of our work a report summarizing the task force's findings, our research work, and our policy recommendations to the legislature, to market participants, and to the administration. The law provides pretty broad authority for this task force to study maternal health data, as outlined on the right-hand side of the slide. This includes data on essential service closures from inpatient maternity units in acute care hospitals to birthing centers and office-based providers of preventative maternal health care. We're also charged as permitted to investigate the quality and safety considerations included in the essential service closure process, as well as the demographic data of the patients who have been most impacted by such closures. And this research will contribute to data-driven policy recommendations, and I believe ambitiously will contribute to a national conversation on improving maternal health care. This is a top priority for the Health Policy Commission. We are committed to providing the time, resources, energy, and staff to making sure that this task force is a success. I want to acknowledge a few people who you'll be working with in the course of this task force. First, as I mentioned, Jasmine Bland is going to be the project manager for this task force and point of contact for all of you. In addition, we're really excited to be able to leverage a new mandate for the Health Policy Commission, which is a new Office of Health Resource Planning, which was established as part of recently passed healthcare legislation. This Office of Health Planning is really about having a process for proactively aligning healthcare supply with healthcare needs. And so we see this work of this task force really aligned with that vision. And so I'd want to acknowledge the inaugural director of the Office of Health Resource Planning. We're going with OHARP as the acronym for that, Kara Vidal, who is going to be also working very closely with this task force and helping us think about novel analytic methods, new data sets, new ways of conducting this research, which I think will really, in some ways, be a test run for this new Office of Health Resource Planning. So thank you, Kara. And in addition to both Jasmine and Kara, we have members of our Research and Cost Trends team in the room as well, and our Office of Chief of Staff, who is really helping with all of the logistics and planning for this task force. So between the Health Policy Commission and I know the Department of Public Health, we are really committed to making sure and putting as much effort as we can behind the success of this task force and your work and supporting your work. So with that as a broad overview of our task force mandate and some of the past work, I'm happy to turn it back over to our co-chairs to begin the discussion of how we might move forward on this agenda.
All right. All right. Thank you so much, David. So the bulk of the rest of the discussion today will be really interactive and an opportunity for you all to share your feedback on the proposed work plan. But first, to guide our discussion, I'll start by providing an overview of the work plan itself, as well as the potential proposed research methods that we want to sort of use as a jumping off point. So if you take a look at the slide, yes, so phase one, we've already done. That was most of the pre-work to get us all here today, the behind the scenes work. And I thank the folks at DPH for doing quite a bit of that, and folks at HPC. So we're here today at phase two. And based on the discussion that we have here, we'll begin the study of a broad range of data related to maternal health care in Massachusetts. And this data includes, as David mentioned, data on the current availability of and access to maternal health services, past essential services closures, the closures of community-based, office-based, and preventative maternal health care. And I just want to comment that on these two bullet points on the matter of closures, the hope is to really apply a critical lens to try and understand what factors precipitated closures and what the impacts on access, safety, and quality were in the aftermath. This phase also includes the study of patient quality and safety considerations, as well as demographic information on patient populations. And this piece is where where data equity is really important, as we want to make sure that we include the broad range of population groups to ensure that in the Commonwealth we provide access, equitable access to care. So our hope is that research can begin expeditiously and that the task force can convene again in May or June to discuss preliminary findings as well as a more detailed research plan. Right. So I think we're on the next slide now. All right, so phases 4 and 5 will really conclude the work, which will involve the task force's recommendations and our final report at the end of the year. And so as part of phase 4, the plan is to bring the task force together in July to review past essential closures and discuss methods to increase the financial investment in and patient access to maternal health services across Massachusetts. Phase 5 then will involve the task force reviewing research findings, drafting the final report, and submitting the report to the legislature by the end of this calendar year. So I know I just zoomed through that part. I was asked to present the work plan. I think the speed at which I described it is not representative of how long and involved it will actually take, because we do have quite a bit of rigorous work to do. But here we have a high-level summary of the work plan. And yeah, you can see we have our work cut out for us, but I'm excited to dive in. So I'll pause here for a moment to see if folks have any questions on this piece. All right, this was circulated to folks, right? All right, okay.
I'll admit to having skipped ahead of slides, so please tell me to wait if needed, but I noticed in the detailed piece on the research piece of the work plan,
Yep.
there is not reference to the financial sustainability of these services. It's referenced later and under potential research methods, but I wanted to make sure that would be part of the.
Definitely. Yes, thank you for raising that. So that's a central part of the work. And while I'll get to that, I think on this slide or the next one. But we do have designated time in this agenda to discuss all of that. But absolutely, the financial piece, financial sustainability is at the center of this work. All right, so are we on potential research methods? Okay, so as we mentioned, we absolutely plan to bring to bear all of the skill sets of the folks here at HPC, at DPH, everyone around the table, to really conduct a robust analysis of access to care in the Commonwealth. And towards that end, we'll adopt a mixed methods approach to both data collection and analysis. The plan is to utilize all of our diverse resources, experiences, and really the knowledge and expertise that all of us and all of our organizations have to bring on this issue. And we'll have data from a few different buckets. So the first bucket is quantitative data that will be drawn primarily from resources such as population level data sets, as well as local and institutional databases, which are on a relatively smaller scale. We'll also utilize geographic specific data, which will allow us to map areas of need, sort of regionally and also at a more granular neighborhood level and proximity to services. Then turning to the qualitative data, which always gives us really a lot of rich insight into the experiences and narratives of patients, birthing populations, as well as the workforce. We'll compile our qualitative data using existing resources. So some of that will include past listening sessions, like listening sessions carried out by DPH and other partners, as well as primary data collection through focus groups in-depth interviews with key stakeholders, obstetric providers, including midwives, family medicine docs, hospital administrators, providers in ancillary settings such as emergency departments, community health centers, and more, as well as importantly with pregnant people and their families, doulas and community birth workers. So that is not an exhaustive list, and I'm sure folks will have additional ideas of people to reach out to and interview and include in our focus groups and interviews. So please bring those to the table as well. And so for the third data bucket, so to speak, that will be data that is primarily about healthcare financing. So these measures will, in large part, because of what we have available, be quantitative, and they'll include data that the HPC and CHIA collect pretty regularly. And so these include things like the current rates and methods for financing healthcare services, including data by payer, insurance type, out-of-pocket costs, as well as challenges with the current payment system. Third, we'll also include measures on the cost of care by different levels of maternal health care, so the ACOG levels that we're all interested in taking a closer look at. And finally, financing measures will include potential innovations in healthcare financing that have been tested in Massachusetts and across the country. So again, a lot of these measures will be from quantitative data sets, but this data can also be captured qualitatively. I'm sure there's a lot of insights that we'll glean from interviewing folks in the hospital setting, interviewing people in other clinical settings and in communities around how our current state of maternal health financing impacts them and impacts their organization. And finally, we'll also examine the workforce, importantly. So we'll examine trends in Massachusetts maternal health workforce, including the counts of OBs, of CNMs, labor and delivery RNs over time and by zip code and region. And of course, again, this list or these examples of the maternal care workforce is not an exhaustive list. So please feel free to bring your ideas to the table as well. So again, a very rapid overview of what will be a very involved process. But Dr. Alonso Lord, do you have anything to add at this point? Okay. Okay, so if folks don't have anything to add at this very moment, let's turn it over to the structured discussion that we've prepared, which will be an opportunity for everyone here to weigh in on first the work plan, because that's not set in stone just yet. The work plan, as well as the proposed methods and the questions and the themes that we presented here. So we'd love to hear from you about first, have we covered everything? Should we cover something differently? And also, what resources does your organization have at their disposal that they'd like to bring to the table for this work? So we can start it. Why don't we start it there with the first question? So what resources does your organization think it would like to bring to this work? Do you have interns? Just kidding.
I think I could start. Well, with my organization, we have the patient safety, the quality piece of it. We've looked at data. We also have access to data through CHIA, obviously, who we partner with consistently. So we can bring some of the research, the quantitative data analysis piece to the work and try to sort of see how we could identify where the issues are. You know, there are definitely access issues, but how does that? So if a person where to go to a birth center, have a delivery, and something goes bad, what's the next step, right? So trying to see how we can link up all the different transfer routes and see how we can use data to sort of see where each person could go to and receive the best care. That's sort of the angle we could bring to the table.
Wonderful.
From CHIA side, I think we can have data on some of the financial utilization piece from the hospital. So the CHIA cost report was at least 2015, and we do have it broken out by revenue centers. So we will have payment, but we will have charges for the center as well as cost. I think we also, from the cost report, have staff beds and staffing ratio. And I think from our case mix data, like Goodwin alluded to, we do have it by a quarterly submission, so we can track utilization. And the case mix go back to in the 2000s in terms of for different hospitals. And so from that perspective, we can see the actual utilization at the hospital. And our team have been able to identify it, obviously, by the DRG of deliveries, as well as by patient demographics that's available in the case mix. So I think those are two pieces that CHIA does have at its disposal right now.
And I can add from Pinquin, especially for the second bullet, as I mentioned before, what we do is we convene healthcare providers, and we have relationships with all 39 birthing facilities. We're also working really closely now, or have started to work closely with the Mass League of Community Health Centers to engage them more in Pinquin. So I think for focus groups and qualitative data, we can certainly help bring people together.
Excellent.
I'll add that we are a nonprofit with 3 FTEs. We don't have too much to offer, but we have access to a national network of birth centers. And I think that there are some models, in particular, the question around innovations of healthcare financing that have been tested in other places. There's some models of insurance reimbursement in Oregon and Washington that we can bring into the conversation.
Great. Great. And are those models specifically around birth center reimbursement?
Yes.
Oh, awesome.
Maybe more broadly to midwifery reimbursement, regardless of location of birth, but they've been leveraged by birth center leaders.
Oh, great.
Policy change.
Great. Fantastic.
Excuse me, thank you. In terms of the Mass Medical Society, really able to sort of do some convening across specialties that are involved in maternal, and I would also encourage us to think a little bit about pediatric and neonatal care as a place where new families interact with the healthcare system. And so we have this committee on maternal and perinatal welfare that includes both maternal and infant providers, and are happy to think about things like going into question 2, possibly survey. We certainly can, call on our members who are part of ACOG, American Academy of Pediatrics, American Academy of Family Physicians, and whatever the emergency medicine equivalent of that is, to sort of draw on the different specialties.
That would be great. So are you saying that you can help us recruit some docs to interview? All right, thank you.
Similar to Dr. Shields and Dr. Price, the MHA representing all the acute care hospitals in the state can facilitate those types of conversations. I know our clinical affairs team works closely with Dr. Price and Pinquin, and we also have a maternal health work group of MHA members and a committee of our board, the Clinical Issues Advisory Council, made up of clinical leaders across the hospital that we use regularly and can in this context. And then just another area I would note, I don't believe any data would be available yet, but our Mass Health team and health equity and clinical affairs teams working closely with Mass Health on the Mass Health waiver, which of course is first in the country to be focus so specifically on health equity, and there are a lot of measures in there related to birthing. And so I don't believe that the timeline would quite line up for the report, but I think in terms of context, it would be helpful to for the report to reflect that that work is underway.
All right. I actually have a follow-up question for Chia, for Dr. True. Am I pronouncing that correctly? Okay, wonderful. So regarding the case mix data, you mentioned that there's demographic data available, including race, ethnicity. How accurate is that data? Do you generally trust the race, ethnicity data in that data set, or will we have to draw from other sources?
I think for the most part, I think we are very comfortable with the race ethnicity data from the case mix. I think that has been standardized, I think, in previous convening of DPH quite a while back. So I would say, and it's fairly complete as well. So it's, I would say, across the different data sets, especially we're able to link patient across with a unique ID that we generated from other demographics, that's other identifiable information on the patient record. I would say it's near 90 to 95% completion across all records. And I would say we reliably use that race ethnicity field.
Great.
And I'll just add to that, one of the kind of recent research innovations that we've done at the HPC is being able to link that case mix data to claims data through the all payer claims database. The race and ethnicity data in the all payer claims database is generally not reliable. But being able to link members from case mix in the hospital to that claims data, we can kind of import that information to that member. And then that provides us an opportunity to look at care, not just in the hospital, for those members. What happened before the hospital, what happened after the hospital stay, what types of services were being provided, prenatal visits, postpartum visits. And so can get a much broader profile of those particular patients, their diagnoses over time and their engagement with the healthcare system, not just in the hospital setting. I will raise, I think one of the challenges in some of the data is that the hospital data is all really pretty good and comprehensive and complete. And so how do we, what data sources are we going to need to think beyond just the hospital setting and understanding access to care pre, post, and other methods and interventions?
All right. So why don't we turn specifically to the question around resources for qualitative research? Because the qualitative piece, although the stories and the accounts that we get from it are rich, and there's no doubt that they help us to do our work better, the workload tends to be very involved. So, although we will be working with we will have some help with it, but in terms of resources, the kinds of resources that we would need would be help with recruitment, with reaching out to folks in communities all across the Commonwealth in specific regions. So what do folks think that they could offer in terms of assistance with that?
Yes. Will these be in person or virtual for that?
Yes, so that I think is still to be determined, and that could be different based on whether we're interviewing a group of physicians or a group of other stakeholders versus we're interviewing in a community setting. So I think we're open to different types.
I also have a clarifying question, Dr. Gerard. The human resources to do the research, is that DPH and HPC? And so we can, like who's doing the work?
So the plan is, I don't know how much of this we're going to put on the table, but the plan is to contract it with an outside firm to help us with some of the logistics around it. In terms of who's actually doing the interviews, though, we can be open to designing that however we see fit. For instance, I think I'm very mindful of, having someone who's culturally competent doing these interviews. And if we can, someone who's from the communities that we're interviewing. So I am happy to work with any of the students, graduate students, undergraduates, and folks locally and in Boston and elsewhere to work on the interview side. We could put together some funding and hire these people, or we can draw from our own organizations. So I said interns, even though it's not always the best solution, but
There's some resource and infrastructure.
yeah, there is.
Yes, just to add to that, the Health Policy Commission is committed to dedicating the resources to the work of this task force, including if we need to, work with others to expand our capacity, expand our reach. Full commitment there. I think on the qualitative piece, just to add on, there are some elements of the charge that have us, task the task force with looking at, impact of past closures and what has been the impact for, people in those communities. Certainly that might be one area of interest that we would want to focus in on. More largely or widely, is there an opportunity to speak to members of the community about how they perceive access to maternal health care that may provide additional information beyond just what we can see in the numbers of, different providers in different areas and doing drive times and maps like that to be able to complement some of that analytic work. So I think there's really a broad opportunities to go a couple of different directions with that particular piece, and hope to hear from the task force about some priorities.
And I think that's where we really want to tap into parenting networks. So our early intervention, our home visiting systems, anybody who has their child in some sort of child thing went through the process of getting that child somehow. So I think that's a place where we can go beyond the folks that always show up to the listening sessions on doulas, for example, that we've done over the several couple of years, and just thinking very strategically about the other thing that's top of mind for me too is families. As when you brought up Haitian families, is families that have moved through the shelter system during their pregnancy and postpartum.
Mm-hmm.
And also listening to again their perception of safety and access through that. As somebody who's very focused too on the Latino community, just thinking about how to, what's going on with documentation status right now is impacting people's perception of access. Can I show up in labor? Should I wait till I'm crowning? Kind of,
I think the other piece of resources would be to include the resources necessary for interpretation and translation to make sure that we're not doing just English-based focus groups or interviews.
I think what we can bring, and Dr. Alonso, I think I heard you say this, but I don't see it listed on page 14, about like increasing the number of birth centers. Is there kind of dedicated research to thinking about how we do that? So we are convening, there are 7 birth centers in the state that are in the development pipeline in various stages. And so we've convened them recently and can bring that group of stakeholders to the table and to figure out what is possible and what's getting in the way.
Dr. Alonso's point, our hospitals are already reporting, significantly reduced presentation of patients related to their immigration status and, fear, even, warranted or not, there's fear. And also, I think some facilities have seen an uptick in presentation very late in pregnancy, often near some of where the migrants have been housed. And so I think, I don't know what how feasible or willing folks would be, but I think maybe speaking to some of those communities in particular would be really beneficial.
I just wanted to say that I think the biggest hurdle will be recruitment. Yeah, when you look at the migrant communities, they would be kind of challenging. People are trying to stay hidden, so how to recruit them? So we have to think creatively about how to get them on to come to this council.
Just to add onto this conversation, I think while not contemplated in the charge of the task force in the legislation as the legislation passed in August of last year, there are real impactful changes that may be occurring in real time to maternal health care support from the federal government, for maternal health care workforce from the federal government. Recent elimination of key programs at CMS and HRSA that support much of this work. I think one opportunity may perhaps for this task force is to be able to document some of the risks that we see there, what is being lost, and perhaps have some strategies about how best to backfill the most essential pieces where we can. There's real-time context that will be happening in the course of this task force that I am mindful of.
Right. So with that in mind, why don't we turn to what folks think might be missing from the current proposal? So David brought up an excellent point that things are changing very rapidly in real time, that will absolutely impact the health system here and the system of maternity care here. How can we capture that in the research? And also, I'd like to raise that even how we think of and how we measure access is so multidimensional. So it's not just driving times and proximity, and it's not just what insurance network are you part of. It's also questions of when you show up, will you feel welcome or will you feel ignored and snubbed and discriminated against? It's also when you show up and you have your child with you at an appointment, are you going to be afraid of having Child Protective Services called on you or the police called on you at those moments? So I think there are a lot of ways that we can capture access in this work that I don't want us to sort of lose. So any ideas there about what might be missing, what else we can do?
Piece of that we've also become very aware of is the sort of the reputation of spaces. Is that hospital safe for my people, or is that a place where they're going to call ICE on me? And we all know that there are certain hospitals that certain communities say not there. So I think that's a critical piece of access. You might have a hospital in a neighborhood and nobody shows up.
I also think this is in line with the implementation of levels of maternal care, but access, it's not just about, can you get to a birthing facility within 20 minutes, but can you get to a birthing facility that's going to be risk appropriate for you if you have diabetes or, other complicating factors.
Just add, in the trends in the maternal health task force, it says counts of OBs and CNMs. I would add CPMs and wonder if we're also looking at race and ethnicity of the providers, or if it's just about the counts over time.
I think we would
Great
absolutely
point.
fold that information into the analysis.
Yes.
Family physicians who
Yes, yes.
So wondering in relation to the levels of maternity care and the issue of sufficient training about emergency obstetrics for PR docs and the nurses that are left in the places that still have PRs, but they don't do.
Where does that fit into sort of some of the discussion about?
Drills and training for non-obstetric units to be able to
Do the initial
care and if an emergency.
And I'll add to that obstetric readiness of ED, also the EMS, EMT systems that are moving people across. Yeah.
The other thing not sure how to reflect here, but is thinking about how systems of care work related to post and pre and postnatal care beyond just the birthing facility. And so how are those integrated into larger systems that may there might not be a birthing facility in every community, but how is that, but there may be pre and postnatal care there, and how does that all integrate together? So how do we think about that? And then on the EMS point, I think there's some context that would be helpful in terms of particularly for eventual NICU patients, how the air ambulance fits into that conversation. I know we actually were in a meeting recently where MedFlight was speaking about their frequent work in that space.
Just speaking to what Sarah was saying earlier about the family practice providers that have the ability to deliver babies. We had two really good family practice providers at Leominster, which I was able to bring with me to Haywood because they also live in the area. And one of the things the head obstetrician at Leominster had said to me before we closed, had we thought of combining call with the family practice providers 2 years ago, that probably could have saved the unit. As you know, there's a nationwide shortage of obstetricians, people going into OB, and the family practice providers that we have the ability, have C-section privileges, have the ability to do C-section privileges, C-sections. And that's a lot of times why OBs don't want family practice providers to cover them, is because if you need to do a C-section in the middle of the night, there's nobody on call behind you. But if we could maybe figure out how many family practice providers we have in the state that have the ability to do that. We're seeing that now at the hospital that I'm at now, we only have one OB left, but we have the family practice providers that have C-section privileges there. And I said to the hospital, we really need to look at getting these doctors in and combining call, because right now we're running on just one OB and we are just running on laborists. Nobody wants to be in the office Monday through Friday anymore, seeing patients when they can work 2 night shifts and make the same amount of money doing call as a laborist. And this model does not work. It's not sustainable. When we started with the laborist model at Leominster, because of the cost of it, probably a year later is when we closed. It's not a model that works. Unless you're doing a ton of deliveries, your hospital can't afford that model.
I love that point, and I'm going to add to that is how many midwives are trained as first assist
Yes.
in a section,
Yeah.
but we're also in a state where we're about to open the first CNM education program
Yeah.
next year. So again, it's sort of like that,
Yeah.
the workforce, we don't even have enough midwives, we don't have enough
Yes.
family practice.
Yeah.
And then once they're actually trained, do they survive enough years to then start getting additional training
Yeah.
in surgery,
Yeah.
so that then they can be across
Yeah,
the
and
field? So
we were lucky enough at Leominster where we had a midwife. If she was on call, we'd always have an OB on call behind her. If we had to go to section, she could act as our first assist. Where we don't have that at Haywood, but we do have first assists on call that are within 10 minutes of the hospital, so they could come in. But it would be nice to have somebody in-house all the time that could do that.
The workforce. One piece of it is there's a shortage and other people to also
Yeah.
leaving, so we may need to also leave in to understand why they're leaving the workforce.
Yeah.
And see how we can keep them working, because if they all leave, then certainly.
Yeah. And a lot of them I've talked to said that it just burnt out, you know what I mean? So when I talked with Doug Brown at UMass when Leominster was closing, I said, what about if we have this huge OB residency program at UMass. What if we offer the new grads at UMass, the OBs, tuition reimbursement? That would be like huge. You come work at a community hospital for X amount of years, we'll pay your student loans. The OBs are like, oh my God, that's like brilliant. They're like ready to retire and they're still paying their student loans. Something to entice them to get them into these small community hospitals where we can't find an obstetrician.
I'm thinking about the research methods. I think one area I do wonder about is kind of like how much does the patient know about the availability of midwifery doulas that are accessible to them? Especially in communities where language is a barrier. You may not even know what kind of coverage you have under Mass Health, if you have Mass Health. Even for commercial coverage, right? In terms of, I know that we want to build all this infrastructure to have the availability of midwives, doula, all these services. How much patient education do we need to make the patient be comfortable that I want to go to a midwife for delivery? And I think for myself, personal experience in terms of years ago, is that option wasn't introduced to me until very late into my pregnancy. By that time, my mind is set, I'm going to deliver a BI. So I think when does that conversation come up for the patient? And I think some of the qualitative work may help us to think about when you're speaking with the patient or even community centers, like when are people introduced to that concept that there is an alternative? I don't have to deliver at the hospital. Yes, I think there is a much broader conversation that we should have babies at the hospital to be safe. And I think that is a conversation that I think will be important, especially think about sustainability financially as well, right? Where people choose to go matters.
Yeah.
I have a question more than anything else. Your point around family physicians with C-section privileges,
Yeah.
is there a place where we could have that data on? Do you know, would Borum collect something like that? If someone has C-section privileges?
So the privileges are given by
Right.
individual hospitals,
Yeah,
so
I don't know how to collect that.
maybe it's something Pinpoint could help with.
Yeah.
Yeah, it seems like a survey, to send around family practice and CNM professional associations in Massachusetts and just sort of say, okay, of this random sample of 100 people that hopefully could give us an idea, but it's not trackable. It's sort of,
There's no differentiation on the birth certificate between about what kind of physician delivers a baby. That might be for CNM or CPM, but you can't differentiate the specialty of the physician based on the birth certificate. That's manageable. I was also thinking, and I'm sorry if I'm not speaking into the microphone, but the button is a little. I was thinking about hearing about a program several years ago in rural Iowa that was really doing some interesting work around multidisciplinary coverage with a general surgeon, a couple of family docs, at least some of whom had C-section, but not all of them, and then midwifery and anesthesia, and sort of thinking about how, that particular small hospital that was dealing with closures around it, set up this system with a team of people with different kinds of skills that could provide a group coverage. When you're thinking about the sort of cross coverage. So maybe there's opportunities to learn about, sort of national networks, like other places in the country that are looking at the sort of rural access issues. I don't know what Massachusetts is defined as in terms of rural, but and not what kind of models have come up.
we do have within DPH an Office of Rural Health. And within that, Kristen and I are actually working very closely with the person who works with rural hospitals in Massachusetts. We do have a point person for that.
And so Dr. Shields' point, in Massachusetts, we have rural hospitals, but they're not
as
not
rural as
as
Iowa.
rural as some places. So I think
Iowa.
that I look at, models across the country or any case studies from across the country would be helpful context too.
Yeah, and I think taking a look at rural hospitals as well as birth centers can give us some insights as to sort of what relatively lower volume obstetric sites need, right? So as far as payment solutions, they often face similar issues, rural hospitals as well as birth centers.
That point, Dr. McGregor, and I'm not sure where it was in here, some of the kind of root causes of the closures that we've seen, I think are also related to the challenges that birth centers face to open, right? So the reimbursement rates, if
Yeah.
hospitals were getting reimbursed
Yeah.
appropriately as birth centers need to be, then we can also maybe avoided some of the closures
Yeah.
where hospitals have cited, in particular, the closure of alongside birth center units,
Yeah.
hospitals have cited financial hardship
Yeah.
in the reimbursement of the midwives who staff that facility, so.
I just want to add to that. I think that's a tremendous opportunity. And as I think about the specific analysis around impact of closures and trying to understand what those root factors, what those root causes were, that will help us be able to put in place the right strategies to prevent that from happening in the future, right? And to be more proactive about what we want to maintain and secure in terms of access, rather than constantly being faced with a situation where we're being reactive to a situation that has deteriorated to a point where maybe an earlier intervention could have maintained that access point. So I think some of that impact work really is about planning for the future and putting the right policies and strategies in place, but understanding what led to that and what the impact of that has been. I think could be a really useful part of that analysis. And just to add to some of the great commentary about some of the workforce analyses as well, we just at the Health Policy Commission issued a pretty comprehensive report about the state of primary care in Massachusetts, and within that we both looked at kind of the range of different types of providers who provide primary care, where we, how many, who are they, where are they located, what does that pipeline look like into the future, how are payment differentials play out between different types of providers, and what are the barriers and burdens for people choosing to go into this particular practice field or to continue to practice, and issues of burnout and administrative burden, and we're, of course, top of mind to that, but also payment. And, I'm reflecting on an earlier comment, while it's great that Mass Health has established payment parity for certified nurse midwives, that doesn't extend to the commercial plans. And so I think this task force can think about what are the types of policy recommendations we want to make, put in place to strengthen and stabilize the workforce and make sure it's right sized to the type of care that we want to try to promote into the future.
It might also be helpful too, if we look at what Mass Health pays compared to commercial
Yeah.
insurance. I did a lot of research on this when we were going through our closure. And from the time you get pregnant till the time you deliver, Mass Health pays about $6,000 for a delivery. Whereas if I went in with Blue Cross and Blue Shield, it pays $26,000. So if you look at these units across the state that are closing, they're closing because they're servicing 90% Mass Health patients. Hospitals very similar in size, Emerson Hospital, are thriving because they have patients that all have commercial paid insurance. So if we can look at maybe the differences in that.
I would just add to that, similarly, birth centers are, for Mass Health and commercial insurance, getting about 1/3 of what the hospital is getting for reimbursement. So if the hospital is being under reimbursed, the birth center is as well. And we have access to that data.
To build on all of those points, I think it's also, helpful to remember, like the Heart BP program, for instance. Really excited to see that innovations in care, innovations in delivery. Mass Health will be covering it. We have not seen yet that the health, any of the commercial plans will be. I think, also working a lot in the behavioral health space, we often see Mass Health out in front of these care innovations, and it taking longer, or if ever, for commercial plans to cover those services, which is a big barrier to the sustainability of them, that in part because of the the lower reimbursement rates for Mass Health services. And then back to David's earlier point around the federal uncertainty, we're talking about $880 billion in Medicaid cuts. Even Mass Health's ability to cover some of these services would of course be in jeopardy.
I wanted to bring up, and I was thinking about the comment about the pre and postnatal care that happens in communities where there isn't a birth center or birthing hospital, and thinking about the sort of handoff and communication and transitions of care for families, and how there's a lot of gaps in that, and what can we look at in terms of the places to bolster the technology and other standards of communication across the different places that people get care in during their pregnancy journey and their postpartum. Sometimes I have no records from the I mean, that's a little bit better than it used to be, but we're still nowhere near the what was it called, health information highway that we were supposed to have, and that kind of thing. And then there's also the issue of that sometimes the baby has pretty, is sort of automatically qualifying for Mass Health, but the parent loses insurance. And so how can we look at those issues too, in terms of gaps in the care along that journey?
So this has already been quite a rich discussion. And we can see that there's a lot, there's a lot for us to capture in this work. But I feel good about the work that lies ahead of us. I think we still have one or two questions to try and get in. Are we okay on time?
Mhm.
All right. So at this point in time, how does everyone feel about the proposed sequence of the work plan? It's broad for now, but does it seem reasonable? Again, we'll be doing the bulk of some of the heavy lifting of the analysis through our meeting in May, right about in May. June, we'll discuss the detailed research plan and analytic approach. So that'll likely be our next meeting. And by the time we get to July and August, we should have findings to review. So it's a tight timeline, but all the issues here are urgent. We know that. So we're committed to meeting this timeline. Does it sound okay? So,
I guess I have a question about if we're meeting May, June to discuss the approach and we'll have data in July. Does that mean that all of the data collection and interviews and focus groups will happen between June and July?
I think the,
It could be.
yeah, no, I
I'm
think some,
optimistic and I'm here for it. But
I think some of the pieces will naturally take a little bit longer to put in place. I think our approach on doing focus groups and interviews, I think we want to be really strategic about what that is. And that to do that well and to do that right does take some time. What I would think is at our next meeting, and I think we wanted to leave it open to hear from you, the task force members, about just kind of sequencing and but is to really kind of synthesize this conversation, organize all of the different pieces we've talked about today into, okay, here's a key question that we want to try to have some insights on. What is the data that we're bringing to this? Do we want to bring qualitative interviews into that question? And then, have that kind of detailed plan to work with you all on to bring to you at the next meeting. get your input and on that, even between, well, I should say, we have already started to work on some of these questions and pulling the right data set. So trying to do things concurrently in some cases, but I think there was just, as you said, a really rich conversation, and I want to put it into an outline and a structure and bring that back.
Sorry, I read this as looking at more of the historical data that we have currently, and then see what questions cannot be answered with what we have currently,
Mhm.
and then sequence into what we need to answer those questions. I know there were listening sessions, we can sort of start from there. We also have some of the quantitative data from GIA and BLC, and then see what questions we can answer with what we have, and then we'll plan from there. That's all I need.
That sounds great. Yep.
All right. So definitely recognizing that the timeline is ambitious, it's tight. Sounds like we're all in agreement that we are up for the task. All right, so in terms of resources and relationships, does it feel like anything is currently lacking at this point? Do folks see obvious gaps or things that we haven't thought of or maybe anticipated? Right. Of course, we can always think about these and sort of follow up
I
offline.
wonder, I know they're
Yes.
not part of this group, but the community health centers, I feel like are an important
Yeah.
piece of this conversation too.
Mhm. Right, I think that's right. And when Dr. Price mentioned your relationship with the Mass League, I immediately thought, why isn't the Mass League here on this task force as well? I think they would be a very important voice, and certainly involving the community health centers in this work, I think is very important. So thank you. Anything else? Right now? All right, so what are some potential threats to the completion of this work? I'm not going to mention the timeline again. We all see the timeline and how tight it is, but what are the threats to sort of meeting our timeline?
I think the elephant in the room is what's happening federally. Are we all going to solve jobs by the time this is over? And actually, I think state data will still have access to, but I think a lot of the data on the federal level, if we were going to look at anything, is being.
Right. Yeah.
So watching the federal and state needs to be
Mhm. Right, they might not have the bandwidth to even do that. Right. I think for some of the data access issues, some of that we've been able to anticipate. There's some data that we already have and have downloaded, and it's in our possession. And I think for the most part, we have the most recent data for state-based, on the state-based side. On the federal side, yes, that is a question. And I think PRAMS is one example of that. Not sure what other data sets folks are seeing that have been erased. Right, PRAMS. All right. So in terms of small group subcommittee work, do folks see an opportunity for us to sort of divide up into smaller groups as a way to get this work done? Are people keen on doing something like that? Zoom breakouts? All right. Anyone have specific suggestions there?
I feel like between. Reach a lot of providers, more in the hospital setting and less so in the community, so that could be one.
Great.
I don't know if there's enough call for a work group on this, but I think the closures and the birth center potential would be like, maybe that's work of a work group.
Definitely. Mhm, mhm, mhm.
Might be the same, it might be the same, yeah.
That's definitely an overarching theme. All right. Okay, so we have sort of a provider subgroup, a closures, birth center subgroup, financial sustainability.
I'm curious with the provider, the big question is, yeah, we know everybody's burnt out, and so what? And being able to answer that question carefully and well as sort of the next step. Because if I was a provider and next year I read a report that says I'm burnt out, I'm like, really? This is what you did this year?
Well, on that note, how would we consider the work of the task force a success? What would we need to have done in the end to feel like what we did together was successful? Right, so we know we'll produce a report, but what will it take to make that report actually impactful?
I think a report that is sort of actionable policies or plans that we can clearly track how they're implemented and how they make an impact. Not just any policy, big fancy recommendation, but specific with clear steps on how to achieve them. I think that would be my success.
All right.
We've mentioned this a couple of times, but I think truly, if we can really truly come to an understanding of why hospitals have closed. I think we have anecdotes, but if we can really understand the root cause and then turn that into actionable recommendations, I think would be a huge success.
Right, most definitely. Right, so to follow up on that, the root causes and the consequences of hospital closures, obstetric unit closures, birth center closures, that's really going to be sort of the crux, sort of the center of our work on this task force. So I think if there's anything that we hope to be able to shed additional light on, specifically in the Massachusetts context, and generally speaking, I think that's it.
I have a question reflection, which is how in the methods of research, this is not to be answered now, but it's just a musing. Do we get at the root cause beyond financial, right? So there's just like a cultural divestment and disbelief in midwifery, right? There has been 100 years of structurally advantaging obstetrics at the expense of midwifery and community midwifery. So I think that like a hospital administrator could say, that financially we had to close this birth center. And what we know to be true is there is also a very strong narrative that model of care was not important, not successful, not as high quality. So it's just kind of amusing about how do we kind of get to the soft underbelly, the quiet thing that's not spoken, because we can do all of the financial analysis and it's going to tell us exactly what the administrator said with the closing of North Shore. Right, it was not financially sustainable, and so we can think about how to rectify that. And there still is a culture that advantages hospital birth, and so I think it could be part of a narrative. It could be just something to talk about. And I would wonder who and how might be able to get to those conversations in like a trusted, informant interview.
someone that might come in helpful, for us was Natalie Higgins, one of our state reps. I worked very closely with her during the, closure, and they all met behind closed doors with hospital administration. They presented her slideshows. So it might be helpful if I'm still in contact with her, if we could get some of our state reps here.
I think too, looking at what has worked in other spaces to move the needle. So, very specifically, I'm thinking about the racial inequities report on maternal health generated hundreds of recommendations, of which then the report to the governor pulled out 25 recommendations, of which then AHEM pulled out 6 recommendations for year 1. So we're constantly building, and the bill is the result of that. Everything kind of keeps coming back to this, and we keep coming back to this sort of core central list of values of this is where we're headed. And it's almost like it's like this decade-long building over and over again. When we, at the end of last year, we went back to the governor's report and said, okay, what next for AHEM? We've completed pay parity for CNMs. We're implementing remote blood pressure monitoring. Let's go back to our list and pull out what's next. But we're not inventing something new. We're not like, oh, this list, whatever. So just thinking about the success of that and thinking about how I don't know if copying that directly and taking those recommendations and going further with them from a financial perspective, or something about the fact that it's always on the table. The racial inequities report is always sort of like the center bouquet of flowers that we have to bring into the conversation on maternal health. And maybe even thinking, outside of public health, what are other things that have managed to move the needle on a system? I mean, I think to Nashira's point, like the success of high level hospital-based obstetrics is phenomenal. They've done great. And how can we use that to then make family practice and midwifery and community birth settings also successful? Just sort of thinking radically about what can we learn from things that have worked. But I don't have a strong solution.
All right. Well, I think we're definitely well into time, where I think we're past our expected time. So to close up, do you have any housekeeping items? Okay, so we do have one housekeeping item here. So in terms of housekeeping, we'll be in touch with information about upcoming meetings. And we'll also put together an outline of members' roles in the task force's work as it progresses and moves along. You all have also received information on eligibility for a stipend to participate in the task force. So if you have any questions about eligibility, please reach out to the Massachusetts Maternal Health Task Force email, mamhtf@mass.gov. That'll be the primary point of contact for the task force going forward. All right, so if there are no further comments or questions, or if Dr. Alonso, if you didn't have anything to add at this particular moment. Oh, David.
Just one final housekeeping item. We have created a website landing page for the work of the task force. And included within that, we do have some kind of a resource section of other relevant resources. And so invite all of the task force members, if there are particular reports, studies, things that you've seen that you think would be good for all of us to keep aware of and to have on that landing page. Please email us and let us know. We've just started to compile, some of the DPH reports that we've referenced today, some of the HPC work, but there's so much additional work out there. And so want to have a really trusted library of resources there. So encourage you, as well as those of you who are watching online, to participate through that email account. We will also be keeping the public aware of the work of the task force. And so I just wanted to mention those two final things. And then just to close out, I just want to also reflect that the Health Policy Commission is also going to be working this year on a primary care task force. which is going to be co-chaired by Dr. Kiami Mahanya from the Executive Office of Health and Human Services. And I think there's an obvious linkage and connection between the two works of these task forces. And so I'm encouraged by that opportunity for being able to kind of share how and what we're learning across these two task forces to have a more complementary approach to recommendations at the end of the day. That task force also is going to be working on a very ambitious timeline and schedule for its work. So I just wanted to mention that great opportunity as well. Thank you.
Right. Thank you. All right, so if there are no additional comments, I guess we will adjourn this meeting and go to the after party.